Welcome back to Med School Content. I'm glad you're here because today we're covering one of the most commonly tested drug classes on boards and one you'll prescribe almost every single day on your clinical rotations, diuretics. We're going to walk through all 5 classes together, organized by nephron segment, so by the end you'll have a single framework that explains the mechanism, the electrolyte effects, and the clinical use of every major diuretic you need to know. Let's get into it. Before we start, this video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. With that said, let's dive in. Before we talk about any individual drug, I want you to have the right mental model. Every diuretic you'll ever use works by targeting a specific segment of the nephron, and that segment determines everything: how potent it is, which ions it loses, and when you'd use it. Starting from the top, carbonic anhydrase inhibitors work at the proximal tubule, osmotic agents at the descending limb, loops at the thick ascending limb, thiazides at the distal convoluted tubule, and potassium-sparing diuretics at the collecting duct. Keep 2 principles in mind throughout this whole video. Principle 1, any drug that blocks sodium reabsorption forces water to follow into the urine. That's your diuretic effect. Principle 2, the more sodium and water you deliver to the distal nephron, the more potassium gets secreted there, which means most diuretics cause hypokalemia. The exception is potassium-sparing diuretics, and we'll explain why. Starting at the very top of the nephron, the proximal tubule, we have the carbonic anhydrase inhibitors, and the prototype is acetazolamide. Carbonic anhydrase is the enzyme that normally drives sodium and bicarbonate reabsorption here, so when you block it, you dump both into the tubule. The catch is that this is a very weak diuretic because the downstream segments, the loops and the DCT, compensate by just reabsorbing the extra sodium. So we actually don't use acetazolamide as a diuretic at all. Its niche clinical uses are where it shines: glaucoma, because Ca is needed to make aqueous humor; pseudotumor cerebri, because Ca makes CSF; and altitude sickness, where 125 milligrams twice daily causes a compensatory metabolic acidosis to offset the respiratory alkalosis from hyperventilation at high altitude. On the adverse effects side, the big ones are a non-anion gap metabolic acidosis from bicarbonate wasting, paresthesias, and here's a board pearl: kidney stones. Why? Because acetazolamide reduces urinary citrate excretion, and citrate is what normally inhibits calcium stone formation. Also, it's a sulfonamide drug. Moving down the nephron to the descending thin limb of the loop of Henle, we find the osmotic diuretics, and the prototype is mannitol, an intravenous sugar alcohol. Here's how it works. Mannitol is freely filtered at the glomerulus but cannot be reabsorbed. So it raises the osmolality inside the tubule, which opposes the normal water reabsorption that happens in the descending limb. That limb is water permeable and normally loses water to the hypertonic medulla. With mannitol clogging things up, less water gets pulled out, so more stays in the tubule. The clinical application is osmotherapy. In cerebral edema or elevated ICP, you give 25 to 100 grams IV every 4 hours to create a hyperosmolar state in the bloodstream that draws fluid out of the brain. The key board pearl to remember: mannitol is contraindicated in heart failure. The reason is timing. Mannitol first pulls fluid into the intravascular space before the kidneys can excrete it. So in a patient with HF, you transiently worsen volume overload and can precipitate pulmonary edema. Also avoid it in severe renal disease, where mannitol can't be excreted and can cause anuric renal failure via renal vasoconstriction. Now we arrive at the thick ascending limb, and this is where the heavy hitters work. Loop diuretics are the most potent diuretics we have, and the reason comes down to a dual mechanism. First, they block the NKCC2 cotransporter, which stands for sodium-potassium 2-chloride, and that directly prevents sodium reabsorption, a lot of it, because the TL handles a huge fraction of the filtered sodium load. But the second mechanism is what makes them uniquely powerful. The NKCC2 is responsible for building the medullary osmotic gradient, the concentration of the medulla that pulls water out of the descending limb, and the collecting duct under ADH. When you destroy that gradient, you impair water reabsorption in TWO places downstream. It's like pulling the plug and turning off the pump at the same time. On top of that, NKCC2 activity normally creates a positive charge in the lumen from potassium back leaking through ROMK, and that voltage drives paracellular reabsorption of calcium and magnesium. Block NKCC2, lose that voltage, and you dump magnesium and calcium in the urine. Let's talk about which loop diuretic to actually reach for. Furosemide, also called Lasix because it lasts 6 hours, is the workhorse. Oral bioavailability is about 50% and unpredictable, which matters in gut-congested heart failure patients. Bumetanide is about 40 times more potent per milligram, and torsemide is the best oral bioavailability at around 80%, making it a favorite in advanced HF when gut wall edema limits furosemide absorption. Then there's ethacrynic acid, and this one comes up on boards constantly. It is the only loop diuretic that is not a sulfonamide. So if your patient has a true, severe sulfa allergy and needs a loop diuretic, ethacrynic acid is your answer. For clinical use, loops are first line for any volume overload, HF, pulmonary edema, cirrhotic ascites, nephrotic syndrome. They're also your go-to in CKD with GFR below 30 because thiazides lose their effectiveness in advanced renal disease. And in acute hypercalcemia, loops increase renal calcium excretion, especially when paired with IV saline. Now let's walk through the adverse effects of loop diuretics, because if you understand the mechanism, the side effects practically explain themselves. Hypokalemia makes total sense. All that extra sodium hitting the distal nephron means more potassium gets secreted. Hypocalcemia and hypomagnesemia. We just explained this. NKCC2 blockade kills the paracellular reabsorption pathway. Metabolic alkalosis, specifically contraction alkalosis. Volume loss activates RAS, which drives aldosterone, which drives renal acid excretion. You lose volume and gain bicarbonate. Ototoxicity is rare but board testable. It happens with high IV doses or, classically, when combined with aminoglycosides, which are independently ototoxic. The synergy is dangerous. It usually presents as tinnitus and is typically reversible, but the combination should be avoided or monitored carefully. Finally, loop diuretics can cause acute interstitial nephritis, an allergic reaction in the kidney, and hyperuricemia leading to gout because of how the kidney handles uric acid in the setting of volume depletion. If this is clicking for you, hit that subscribe button and the bell so you don't miss the rest of the drug classes series. We've got a lot more coming. Now let's keep moving down the nephron. Continuing our journey, we reach the distal convoluted tubule, and here's where the thiazides work. Their target is NCC, the sodium chloride cotransporter, and blocking it gives you a moderate diuretic effect. Thiazides are first line for hypertension, and they've proven their worth in landmark trials like ALLHAT and SHEP, cutting systolic BP by roughly 12 millimeters of mercury. The preferred agent in most current guidelines is chlorthalidone over plain hydrochlorothiazide, because chlorthalidone has a much longer half-life, around 45 to 60 hours versus 6 to 15 for HCTZ, and it was used in the most important trials. That said, a large 2022 VA pragmatic trial published in the New England Journal of Medicine showed no statistically significant difference in cardiovascular outcomes between the two in older veterans, so in practice both are effective. Now here's the calcium story, which is one of the most board-tested concepts in diuretics. Thiazides cause hypercalcemia, the exact opposite of loops. The mechanism is a three-step cascade. Blocking NCC reduces sodium entry into the DCT cell, which lowers intracellular sodium, which then revs up the basolateral sodium-calcium exchanger. That exchanger pumps sodium in and calcium out into the blood, so you net reabsorb more calcium. The mnemonic, loops lose calcium. Thiazides take it back. With the calcium mechanism fresh in your mind, the clinical uses of thiazides practically fall out. Hypertension, first line, as we said. Recurring calcium kidney stones. The hypocalciuric effect keeps calcium out of the urine where it can't form stones. Osteoporosis, increased calcium retention may slow bone loss. And nephrogenic diabetes insipidus. This seems paradoxical until you understand it. Thiazides cause mild volume depletion, which increases proximal tubular reabsorption of everything, leaving less water to reach the collecting duct. Now for adverse effects, commit the mnemonic hypergluc to memory: hyperglycemia, hyperlipidemia, hyperuricemia leading to gout, and hypercalcemia. But the one that catches students off guard most often is hyponatremia. Thiazides are the #1 cause of drug-induced hyponatremia. Here's why. They block sodium excretion in the DCT, but, and this is the key, they leave the medullary gradient intact. So the concentrating mechanism still works. If a patient on a thiazide drinks excess water, their kidneys reabsorb all of it while still losing sodium in the DCT. The result is dilutional hyponatremia. Loops, by contrast, destroy the medullary gradient, so excess water just washes out, which is actually protective against severe hyponatremia. We've reached the end of the nephron, the collecting duct, and here's where the potassium story flips. Potassium-sparing diuretics do the opposite of everything else. They keep potassium in. There are 2 subclasses. The first is mineralocorticoid receptor antagonists, or MRAs, Spironolactone, eplerenone, and the newer finerenone. They block aldosterone from activating NSE sodium channels and sodium-potassium ADPase pumps in the principal cells of the collecting duct. Less sodium goes in, and critically, less potassium gets secreted into the lumen. The second subclass is the NSE blockers, amiloride and triantarene, which skip aldosterone entirely and just directly plug the sodium channel. Same end result, potassium spared. These are weak diuretics. The collecting duct only handles about 2 to 3% of filtered sodium, but their real clinical power is preventing hypokalemia from other diuretics and, for the MRAs, delivering a genuine mortality benefit in heart failure. Spironolactone reduced mortality in NYHA Class 3 and 4 HFrF in the RELEVANCE trial, and eplerenone did the same in milder heart failure in the EMPhASIS HF trial. The major adverse effect for ALL potassium-sparing diuretics is hyperkalemia. Be very careful when combining them with AC inhibitors or ARBs, which also raise potassium. One last pearl, spironolactone's structure looks remarkably like testosterone, so it blocks androgen receptors and causes gynecomastia in about 10% of men. If that happens, switch to eplerenone, which is chemically modified to avoid that off-target effect. Now let's connect the dots. When do you actually reach for which diuretic? Hypertension, start with a thiazide, chlorthalidone preferred. If blood pressure is resistant, add spironolactone, one of the most effective add-on agents, especially in low renin states. Volume overload from heart failure or cirrhosis, loop diuretic, furosemide first, or torsemide if gut absorption is a concern. If the patient becomes refractory, add a thiazide-like agent like metolazone for sequential nephron blockade. You're hitting 2 transporters at once for enhanced natriuresis, but watch the potassium. Cerebral edema or rising ICP, mannitol, osmotherapy. Altitude sickness or pseudotumor cerebri, acetazolamide. Preventing hypokalemia or adding mortality benefit in HFrF, a potassium-sparing MRA, spironolactone or eplerenone. And never forget, sulfa allergy plus needing a loop diuretic equals ethacrynic acid. Let's pull everything together in one high-yield table. This is your screenshot slide. For carbonic anhydrase inhibitors, proximal tubule, acetazolamide, used for altitude and glaucoma and metabolic alkalosis, causes hypokalemia and acidosis. Key pearl is kidney stones from reduced citrate. Osmotic, descending limb, mannitol, cerebral edema, but contraindicated in HF. Loop, thick ascending limb, furosemide, volume overload and hypercalcemia, causes hypokalemia, hypocalcemia, and alkalosis. Board pearl is ototoxicity and ethacrynic acid as the sulfa-free option. Thiazide, distal convoluted tubule, HCTZ or chlorthalidone, hypertension and calcium stones and osteoporosis, causes hypokalemia and hypercalcemia and alkalosis, hypergluc, and the #1 drug-induced hyponatremia. Potassium sparing, collecting duct, spironolactone, HFrF, and resistant HTN and cirrhosis, causes hyperkalemia and acidosis, gynecomastia with spironolactone, but not eplerenone. 3 rules to leave with. All diuretics except potassium sparing cause hypokalemia. Loops and thiazides cause alkalosis, while C inhibitors and potassium sparing cause acidosis. And loops lose calcium, thiazides take it back. That's diuretics, 5 classes, 1 nephron, and a whole lot of board testable pearls. If this video helped things click, smash that like button and subscribe so you don't miss the next one in the drug classes series. Thanks for watching. I'll see you in the next video.